everyone. My name's Becky. I'm one of the Adult Services librarians here at the Thomas Crane Library. And thanks for joining us for our next session of our Aging Strong and Falls Prevention series. Now I'd like to introduce our presenter for today, Debbie Lynn Toomey, RN, coordinator of the Tufts Medical Center's Injury Prevention Program. Debbie, thank you so much for joining us today.
Thank you so much, Becky. And again, I want to thank the Quincy Public Library for continuing to allow me to do my outreach work in this manner. I really, really appreciate that. What I do for Tufts Medical Center, injury prevention, and focusing a lot of my attention on falls prevention. And so you'll notice in this program that I try to invite many guest experts who could really talk about different topics, different issues that can contribute to unintentional falls. So today I have George Guara, who is a program manager, complex care and transition. He's also an adjunct faculty at Regis College, Lawrence Memorial. He is one of our case managers at Tufts Medical Center. So, George, welcome.
Thank you, Debbie, and thank you so much for having me today. A great honor to be a part of this great initiative and the collaboration that you have with the library and the community as well. So as Debbie has mentioned, my role at Tufts Medical Center, I'm the program manager for complex care and transitions. And my role entails really working and collaborating, having a multidisciplinary approach for any complex cases that come along at Tufts Medical Center to make sure that we are optimizing and giving the best care as possible for any complex cases. Today, I will be discussing a topic on substance use disorder. And my experience over the years, I've been really interested in regards to how to really help all populations who may suffer from substance use disorder and really getting them connected to the appropriate treatment that they do deserve.
Great.
I'll go ahead and share my slides.
George, as you're preparing your slides for us here, can you just explain to me what you mean by complex care? And what type of patients would fall under complex care and would require your assistance to help them move through the system?
Totally. That's a great question. The name itself, complex, sort of defines the role. And these is sort of patients who come into the hospital with multiple comorbidities that may be affecting each other, not only from a medical perspective, but also from a psychosocial perspective. And what I mean by this is the medical complexity we have for a patient, at times, the root cause of that could be not related to any acute injury, but the root cause might be from either from a psychiatry perspective, mental health, or from us having social barriers, that is having issues with social determinants of health. To start with, I will start by just describing my objectives for this presentation today. First and foremost, it's really to understand how substance use disorder can lead to falls. Second objective will be to describe at least some substances of use in older adults, and also identify barriers to treatment of substance use disorder experienced by older adults. And the last objective will be to indicate strategies to improve substance use treatment for older adults. So what is a fall? We have been talking about a fall. The description of a fall is the downward movement, typically rapidly and freely without control from a higher to a lower level. There are risk factors, different levels for a fall to occur. What are the risk factors? Things that really predispose older adults to experiencing falls. Causation, it's the cause would end up leading to the fall. The result, which is the fall itself, and subsequent of that, we do have the adverse events, which are the injuries that normally occur, from minor injuries, moderate injuries, to very extensive injuries. The Center for Disease has looked at data over time, try to see how have falls been occurring over the last couple of years. They have estimated that the cost of older adults falls on a yearly basis amounts to about $50 billion for non-fatal fall injuries, and also about $7.5 million that are spent on related to fatal falls. So tracking on the right side, we do have the graph that kind of indicate how significant it is and the trajectory that we are on when it comes to falls. They did look at the data from 2007 to 2016 for older adults that indicated that this has increased in 30%. And if this trajectory continues over the years, by 2030, we'll be having 7 fall deaths every hour, which is very alarming. And this makes the topic of falls very crucial for both clinicians, families, and everybody in the community to really support our people who may be at risk for falls. So as we mentioned, the risk factors that are involved that predispose our patient or anyone for risk for falls, it could be from weakness, pain, medication that cause some dizziness, acute or chronic illness, difficulties walking, gait or balance disturbances, hazards at home, having broken items, clutter, or having uneven steps at home, confusion and cognition impairment, which could be medically from a medical condition or also from medications that are being taken as well, visual problems. But my focus today will be on use of substances. A department called SAMHSA have described substance use disorder as the recurrent use of alcohol or drugs causing clinical significant impairment, including health problems, disability, failure to meet major responsibility at work, at school, at home, or in the community. So this definition describes that the use of these substances has really caused a lot of impairment for an older adult to really be able to function well and safe in the community. How bad is substance use disorder in this country? The scope of the substance use disorder has, from SAMHSA and NIDA, National Institute of Drug Abuse, have shown that more than 1 million of older adults suffer from substance use disorder. Another alarming thing is that this is rising. And they have, I think we all know that there is an indication that I had mentioned that baby boomers are people who were born from the mid-40s to mid-60s, due to the culture back then, growing up in an era that drugs were widely available, having economical worries about their job security, retirement, and now we have COVID, and also emotional element in regards to coping with grief and loss. And this disturbs the Maslow hierarchy of needs that we have as human beings in terms of safety needs, love and belonging, self-actualization. So the way we are supposed to progress through this to be whole human beings is disrupted by the substance use disorder. The number of adults, this is a slide that shows from a different lens of the number of older adults who use alcohol, cannabis, cocaine on an average day across the United States. We see that we have about 6 million people who older adults who use alcohol, right about 132,000 and 4,300 for older adults who use cocaine. What causes substance use disorder? There is no single factor that determines whether a person will develop substance use disorder. Rather, it is multifactorial. We do have environmental factors, availability of substances, as we discussed about people, the baby boomers. And also we have the genetic predisposition. People who are born from parents who may have substance use disorder, they do have a genetic predisposition and at higher risk for having substance use disorder. And also we have the intermediate of the phenotype. This is the brain structure and function, which normally focuses on behavioral health, self-regulation, mood stability, novelty seeking, or any sort of impulsiveness behavior that our people may have. Risk factors can be categorized in 3 big buckets: medical, psychiatric, and social. Medical, as you mentioned, chronic illness, pain, physical disabilities, medication. Psychiatry, any history of previous mental illness, history of substance use disorder in early ages, avoidance coping style. and social, transitioning in living or care situations, forced retirement or change in income, and social isolation, which we have all witnessed in the recent past due to COVID-19. And research has shown that social isolation have affected nearly about 1 in every 5 older adults we have in our population. And before I go to the next step of discussing about the specific substances that are abused, I will just open it up to the floor to see if there is any questions in regards to the risk factors that we have discussed.
George, can you speak a little bit more about the social isolation, 1 in 5 older adults? So the information that you provided from the other slide that talked about, is it 7 deaths, 7 fall-related deaths will happen by year 2030. And that was a study statistics that was done from 2007 to 2016. Do you see that the falls will be a lot more than that due to the pandemic, requiring people to social distance and keeping people really from doing their normal day-to-day activities outside of their home?
Yes, I do totally agree with the point that isolation in the midst of the COVID has put people at a higher risk for experiencing falls at home. Mm-hmm. And that is due to older adults being alone, not being able to engage or continue getting the support, the monitoring they had from their family members in the midst of COVID. This could be because if you have a family member who works in a healthcare organization, might be exposed to COVID, the engagement and visiting the family member to monitor them on a frequent basis tend to be less. And also in isolation of all the family members who may have medical conditions that might be very alarming or something like having an autoimmune disease that has recommended to really mitigate any sort of exposure for that. So definitely COVID-19 has really increased the isolation and subsequently leading to higher rates of falls at homes.
Yeah. Okay, thank you.
All right. So as we saw from the slide earlier, that alcohol is one of the most abused drug with older adults. And alcohol, 65% of adults older than 65 have reported high-risk drinking, defined as excessive or exceeding daily guidelines, or at least weekly or daily basis. The National Institute of Drug Abuse have indicated that the parameters for drinking for younger adults is about, for men, 14 drinks a week or 5 drinks by every occasion, for women, 7 drinks a week or 4 drinks per occasion. But for older adults, 65 years and older, they have recommended the safe consumption of alcohol to be 1 drink daily and a maximum of 2 drinks on occasion. Going back to that, NIDA also found out that more than 10% of older adults currently do have binge drinking, which is drinking more than the recommendation, for daily consumption or weekly consumption. And the graph, the table on the diagram on the left kind of indicates when you talk about a drink, what is a drink? Because we do have different varieties of drinks out there, beers, malt liquor, wine, or spirits. And that kind of gives it sort of a visual depiction of what a drink is. So 12 ounces of beer is compared as a drink, 8 to 9 ounces of malt liquor is compared as a drink, 5 ounces of wine is a drink, and 1.5 ounces of spirits is considered as a drink. And we have all come across these red cups, which we normally ask, I see lines around them. Is it because I need to hold it well? Does it help me to prevent the cup from falling? But the lines that are around, the engraved lines that are around these cups normally actually indicate that help us to kind of determine what a drink is. The bottom one being a 1.5 ounce and continuously the 4.5, 7 to 8 ounces and 12 ounces right below the top. So when we are guiding or trying to encourage our family members, our colleagues, or our patients in regards to how can they determine what's the safest amount to drink, using this will be a reliable way of identifying that. So
I didn't know, George, I didn't know that about the red cup. It's very interesting.
Yes, it was quite an insightful discovery when, that was presented in one of the SAMHSA's presentation, and an easy and affordable way of really a comprehension of what a drink can be, depending with what kind of drink that you're having.
Wow, very good. Thank you.
So one of the major things, or really an adverse or alarming adverse event that happens with drinking, is something that we call withdrawal. So there's a risk for falls due to consumption of alcohol, but also when there is a cessation of consumption of alcohol, there is something we call withdrawal. Withdrawal is symptoms that occur when someone stops using alcohol after a period of heavy drinking, and it requires treatment and hospital admissions for that case. So there are special consideration that's normally looked at when we're working with older adults. And withdrawal normally happens within a period of 6 hours post-cessation to about 72 hours post-cessation. 6 hours, you may have some mild withdrawals, mild symptoms, sweating, some shakiness and whatnot. 12 to 48 hours, you may have more serious symptoms, which may include hallucination or seizure. And 48 to 72 hours is the most critical time of withdrawal. You may have very serious adverse events, which include delirium and tremors and very vivid hallucinations. So the special consideration for older adults during this is the onset of withdrawal symptoms may be more insidious and include confusion, which may already be a symptom of anybody who may be suffering from a disease process that may be causing some confusion too as well. So being able to discern the two when this alcohol use disorder will be very crucial. And the duration of withdrawal may persist, particularly in the setting of drug-induced delirium. Some patients or older adults who may be taking some prescribed medication that may cause delirium, and delirium is also a sign of withdrawal. And also considering benzodiazepine tapers with fewer interactions like oxazepam. So when an older adult is going through withdrawal, there are multiple medications that are used, but really when they're getting their medical care, one of the considerations that normally happens in the hospital is use of less interactive benzodiazepine that's called oxazepam. So for older adults who suffer from alcohol use disorder, there are a couple of medications that are used to may help to treat this. These include acomprosate, desulfiram, and naltrexone. So asking if you have a family member that suffers from alcohol use disorder, this is just a part of their treatment. There is more to supporting substance use disorder, alcohol use disorder, more than just medication to really address the root cause of what's causing that. But this can be something that may help to bring somebody to help them cease using alcohol for that case. There is also cannabis. And changes in societal norms or accessibility of cannabis products have shown over time increase in cannabis use in older adults. One of the barriers that we have, there's not quite a lot of studies that have been done in regards to use of cannabis in older adults to really understand the effects it normally has. This anecdotally has been reported that some older adults do experience some symptoms that may lead to risk for fall. The things that I want to highlight about cannabis, if it does cause a person to be concerning as a behavior, so psychotherapeutic treatment like CBT, motivation interviewing, case management, and multidimensional family therapy may be helpful. Treatment of co-occurring disorders, really dealing with the root cause of this. That is, if it's anxiety that's really causing this, really addressing anxiety to mitigate use of cannabis. And also to also highlight that there are a couple of other things that might contraindicated for use of cannabis. If there is any lung function issues or unstable psychiatric disorders or anything that might have any medication that an older adult might be taking that has CNS depression or taking anticoagulants, it's really contraindicated to use cannabis. And the cannabis do propel or we cause worse side effects for this medication and how this medication is processed.
George,
Yes.
we have a question. Let's see, would you consider depression as a cause of all consumption as well as combined with combination of drug mix?
Would you repeat the question again? I'm sorry.
I think the question is, as far as mental, emotional disorders such as depression, would you consider that as a risk factor on top of substance use to lend somebody fall more into the substance use disorder, making it more of a problem than not?
Totally. Yes, mental health from depression, anxiety has shown this quite robust studies that have shown they do put an older adult to be at a higher risk of a substance use disorder compared to older adults that do not suffer from the mental health issues. That is correct.
Mm-hmm. Thank you.
All right, the next substance we'll talk about is opioids. Through over the period of 2010 to 2015, there has been an increase of opioid-related inpatient stays and emergency department visits, where inpatient stays have increased by 34%, and emergency department visits have increased by about 74%. And opiates are prescribed to help with pain management for older adults. But also, given that they do have the addictive quality of that, older adults are also predisposed to developing dependency, which subsequently may lead to opiate use disorder. Over the period of 2013 to 2015, the state and the federal did realize that we are having an opiate epidemic, and there were more stricter rules that were implemented to really mitigate that. And given that older adults were not able to get the opiates they were getting previously from the clinicians, we did see a proportion of this population using heroin to substitute the prescriptions, opiates that were previously being prescribed by their providers. So there's a correlation of reduction of opiate prescribing and switching to heroin. So really addressing, especially understanding that when an older adult is being prescribed controlled substances, opiates specifically, and if the clinicians are planning or encouraging weaning of this medication, if a patient do have dependency or have developed opiate use disorder from that, it's really critical to really identify these so that we can direct the older adults to the appropriate treatments. Just as it is for alcohol alcohol use disorder, there is also withdrawals consideration for opiate use disorder. We do have they are delayed and persistent for a long period of time due to the metabolic changes that come with aging, be more severe and require closer monitoring. Confusion can often precede other withdrawal symptoms, and involvement of support and care transitions is very crucial. Opiate disorder treatment, we have 3 medications also that are really out there that are really helpful to mitigate opiate use disorder. Buprenorphine, which is prescribed by your clinicians, buprenorphine, methadone, and naltrexone. They all have different parameters from their side effects, how they're prescribed. So it's really crucial to, when recommending or advocating for any medication for opiate use disorder, to ensure that it's tailored to a specific patient's needs in the context of any other medical conditions that they may have. And then we do have benzodiazepines. These are prescribed for older adults. We have seen these being used for insomnia, agitation, and delirium. One crucial thing to note is there's not quite great evidence indicating chronic or continuous or longitudinal use of benzodiazepine for insomnia, agitation, or delirium is beneficial, rather using for acute issues. So really addressing the root causes for insomnia or agitation or delirium will be the best approach rather than having a longitudinal use for benzodiazepine to treat these conditions. Cautious use of withdrawals in those who have comorbidity conditions that include pulmonary conditions like COPD, emphysema, and whatnot, because benzodiazepines do cause sedation. Benzodiazepine, there has been a study that was done that indicate that with education of the harms that may come along with that has really propelled patients to be proactive and weaning themselves off of the benzodiazepines for that. So education is a key element to really help to make sure patients, older adults are getting the appropriate treatment for this. So patients were more likely to initiate conversation about discontinuation of their benzodiazepine prescription when educated on the risk associated with the medication. So this is a study that was called the Empower, which was done. And so education is a key and a very crucial element to really help our patient get the treatment that they need.
George, what are other, you might be covering that in a few slides, but what are the more commonly used medications or brand names of medications that's considered under the family of benzodiazepine?
The most common names could be lorazepam. Mm-hmm. You've heard about Ativan, mm-hmm. Oxazepam as well. Mm-hmm. That's another medication that's commonly used. Lorazepam is the one that's mostly prescribed for insomnia and anxiety that's used longitudinally most of the time. So that's one of the common names that we'll see being prescribed for older adults.
Mm-hmm. 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 Thank you.
So treatment and management consideration, we do have for a patient to have a diagnosis or an older adult have a diagnosis of substance use disorder. There's this criterion that is used. And over time, it has been identified that there is special application of the criterion that's done for older adults. A couple of elements remain the same for younger adults, but a lot of different consideration for older adults. A good example will be role impairment is less pertinent. Older adults may retire and may be living alone. So it's really, really hard to discern impairment when there is less involvement in the community and whatnot. Same medication consequences can be serious, including confusion. The same effect substances will have for younger adults. They'll be more serious when older adults are involved. Withdrawal symptoms can occur with more subtle symptoms, such as confusion, which also may mimic or may be very similar to symptoms for other medical conditions that older adults may be having. Older adults may not realize that use is problematic, especially with long-term use. When you've been using medication over decades, over years, you may not realize that that's a problem. And so that really understanding if there is any misuse or any symptoms that may indicate craving of substance use or use of these substances when a symptom is not being addressed. Example will be if you're not really suffering from pain, but you find that you're really requesting for that prescription of opiates from your provider, that might be a sign of substance use disorder. So the difference in older adults for substance use disorder diagnosis, it's really hard to detect under normal circumstances due to less engagement in the community. For younger adults who are going to school, going to work and whatnot, it's easily visible to really see how the substance use disorder may interfere with their day-to-day activities, but it tends to be harder for older adults. Lack of awareness by healthcare providers, society, and family that older adults may have substance use disorder hinder detection and treatment. Even the symptoms may be very subtle as well, that may hinder engaging the older adults for treatment. Absence of previous consequences, as you mentioned earlier, symptoms may also mimic other health problems. And also there is the shame, guilt, and stigma. Older adults may suffer from shame, guilt, or stigma that's being isolated and using this substance in isolation for that case, which makes it harder to address a substance use disorder. So for the treatment of substance use disorder, besides medication, I think family involvement is a key element for this. Loss of independence and need for familiar support may be complicated in older adults with substance use disorder. Really engaging who is their main support at home. Is it their children, or do they have any other support in the community? Or is it having a visiting nurse, a home health aide? Who is their main support in this? Really involving the main support for the family members. Family members' involvement and their main support in treatment is really crucial to ensure that they do have success in the treatment for that. It is also important to address the need of caregivers, people who care for older adults. They may suffer from a burnout. So really asking how things are going and how well they're handling and how well efficient they're doing their support for the older adults. It's something that we definitely need to address as well to make sure that older adults get the best support they can from their family members and their caregivers. One of the things that I like to discuss about, given, as we mentioned, there's risk factors associated with falls, the causation of falls, then the fall as a result, and the adverse events, which could be minor injuries, moderate injuries, or significant injuries. And some of the injuries, significant injuries that may come from a fall, may lead to a condition where an older adult is not able to make their own decision. So, having an advanced care planning with the family members is something very crucial if you have risk factors for falls. And the goal of advanced care planning is really identifying the values and preference for medical care and also designating a surrogate decision maker. And what it normally focuses on for advanced planning, in the event that a fall does happen, and in the event that you do have adverse events, very significant injuries from this, that you might need you may require advanced treatment. It's helpful to really have an advanced care planning ahead of time to choose the person to make a care decision for you when you cannot be able to make this decision, choose the kind of medical treatment you want or do not want, choose how comfortable you want to be, how you want people to treat you, and also choose what you want your loved ones to know. The clinical teams, the family members will do their due diligence to really make sure that we mitigate the falls, but it's also concurrently crucial to really have this conversation in the event a fall does happen in case risk factors that we do not have control over. So I will hold on to that point and just ask if there is any questions.
Well, you've covered so many amazing information. I've been taking notes. But while you are on this slide, I'm so glad that you added this slide because it's just so important, especially when patients enter into the hospital system. So these are questions that, extra paperwork that needs to be filled out as the patient is getting admitted. And sometimes, as we both know, being nurses, this can be very tricky. It could be tricky because it could be a language barrier. The person may not speak English, so it'll be hard to discuss advanced care planning. Or if the person could be, they might have been admitted because of trauma. It could have been like a bad fall that they had, and they're not conscious. Or maybe they are, but they're just in excruciating pain that the last thing they want to go over or talk about is the advanced care planning. Or it could be that they are admitted to the hospital because maybe they have substance use disorder and they are in a state of what you talked about, DTs, delirium tremors, and they could be hallucinating and confused and combative. So can you talk a little bit more about advanced care planning and also healthcare proxy and how, I know we're talking about fall prevention, but because you have the slide, it's just kind of, I feel it's important to kind of talk about this and be able to let people know what it's about and why we want to address this as a person is in the hospital system.
Certainly. So advanced care planning is a really crucial document in form of respecting an individual wishes when it comes to medical care. And it's not one that's normally started with older adults. It can be done at any age. But the value and the significance of this is really respecting an individual wishes and and identifying the person who will serve in your best interest in the position where you're not able to make a decision. And the reason I included this here as well is we have seen falls leading to a lot of conditions or a lot of very significant injuries that require advanced treatments. There is sedation or there is brain injury and whatnot. And when this happens, really having somebody designating a surrogate who will help make decisions in your best, who knows you the best, and will help make decisions for you when you're not capable of doing that. The clinicians in the hospital, they normally would inquire from family members, but having somebody who, it's a legal binding document of that would have a specific person who may be supported by the family members will support in terms of making a decision in the place that you're not able to make a decision. And you may have a primary healthcare proxy, or a secondary healthcare proxy, meaning the to-go-to person initially would be their primary person, and if they're not able to get hold or contact the primary healthcare proxy, the clinical team will reach out to the secondary person. And the value of this is really how do you want your care to be handled? How would you like your care to be handled while you're in the hospital? People have a lot of very specific wishes. So the healthcare proxy is sort of the primary advanced care planning element, designating a surrogate, but it can go further to something we call the MOST, that indicates if any injury happens to me, do I want to be intubated? Do I want to be resuscitated and whatnot? So it's a very valuable document and a very crucial conversation to have with your family members, or that you are able to, before any injury happens or before anyone gets to a state that they're not able to make that decision, they have designated a surrogate to who would make that their health decision on their behalf if they get to that point.
Definitely. It's a courageous conversation that you can have with somebody that you are considering your surrogate, somebody who could speak for you if you cannot, and also offers the healthcare team a seamless way to take care of you. So that way there's no guessing, there's no trying to figure out, what do you think, this person would want? And, so it just allows that seamless care to happen. So, and it's very, very important, especially these days, and definitely a conversation that is important to have before any type of injuries or accidents should happen, or any type of hospitalization should happen.
Totally.
Yeah. Thank you.
All right. And that's sort of the final of my presentation. And just to go through that brief overview, it's really understanding the objectives. It's really understanding how substance use disorder can lead to falls, which we have gone through. These substances cause a lot of lethargy, a lot of sedation, and really make older adults be very impaired, putting them at a higher risk for falls. And also the major substances that older adults use, we've talked about alcohol, we've talked about benzodiazepines that are prescribed for some certain diagnoses. We also talked about opiates, which are normally prescribed for pain as well. And also the barriers to treatment of substance use disorder. The symptoms for substance use disorder for adults are very subtle, and really being able to discern that and having that criterion, as we mentioned, to really discern if the symptoms are for substance use disorder or something that a medical diagnosis that mimics that. And strategies to improve substance use disorder treatment is really engaging with our older adults, approaching this topic in a very non-judgmental way. It's a chronic disease. It's not a behavioral issue, or rather it's a chronic disease. Having these dialogues and directing the older adults to the treatment that they need, reaching out to the clinicians to discuss about that, and getting them the support that they need at home to really address this and prevent further occurrence of falls.
Great. All right. So George, may I invite you to, oh, good. Perfect. I want to see your face so that way we can have a nice conversation here. Again, you covered so many different, really heavy duty information, and I'm sure we can spend the whole weekend really dissecting each segment. When you talk, first of all, I'm so grateful that you defined what fall is, because it's such a subjective term that some people who may have a tendency of falling because of maybe medical conditions or, just being deconditioned in their body. Sometimes they might think, oh, I didn't fall. I just kind of, I caught myself on the sofa, or I landed softly on the sofa. I didn't have any cuts or bruises. So I'm glad you defined what fall is. And to start with alcohol as the substance use disorder, do you find that, I find that when it comes to substance use disorder, there's more of the taboo, which is like the cannabis and then there's one that's not less taboo, or there's less of a stigma around, which is the alcohol, because alcohol seems to be more of a social type substance that allows, we have it when we have parties, when there are weddings. And so it's socially accepted, as opposed to the marijuana or the cannabis. That seems to be more of a stigma. Mm-hmm. What are your thoughts around that, as far as people reporting that they could probably have this type of a disorder? Do you think there's underreporting?
Yes. Studies over time have shown there's a significant underreporting for alcohol use disorder. As you mentioned very clearly, it's well accepted in the community, well accepted in the society, well accepted in multiple cultures across America and across the globe. And identifying alcohol use becoming problematic, it's a very subtle, gradual process from the beginning part of using that. So it's not like when you experience trauma, it's without a trauma to a trauma that's easily visible and easily understandable. But for alcohol use disorder, given of its subtleness and how it develops, people, it tends to continue to be a norm in the community, that it's accepted when that's happening, and that creates the acceptance and not seeing it as a problem creates a barrier of, number one, really directing people to get the treatment they need, and number two, it's associated with a lot of shame, where somebody who's has started to use alcohol recreationally, and that ends up being problematic, where end up having a dysfunctional family engagement, or losing their job because they are quite decompensated or altered and not be able to function for that case. So there is a lot of shame associated with that. And I think those two elements kind of are compounded, where it's a subtle progression, three elements: subtle progression, societal expectation, and also shame of really asking for help, even if anybody is able to identify these alcohol use disorder as being problematic in their lives. So having a dialogue and normalizing the conversation could be a good way of really approaching this in a not judgmental way, non-punitive, or really calling it as a problem, but rather and being very concrete of elements that are visible. When I'm mentioning to somebody that's a problem, rather than just mentioning you do have an alcohol problem or you do have an alcohol use disorder, but supporting that and mentioning about, this is especially people who are very close. Your significant other have realized you're doing X, Y, and Z prior, but this has gone to, it's getting worse. You're really engaged in your role in your work, but you have not been really successful, or that alcohol use has interfered with your work for that case, and you are not able to maintain a job. So making it a normal conversation and really giving people insight to themselves to really understand, to look at those specific elements that might indicate that it's a problem. Yeah.
Now, question about opioids and opioid disorder, use disorder. Many years ago, we were taught as nurses, to address the fifth vital sign, which is the pain, always asking a patient in the hospital their pain level. Are they comfortable? So there was a big initial push to take care of the pain level of people, because we wanted to make sure everybody was comfortable. Can you briefly just talk about how, from that initiative, how that kind of spurred the opioid use disorder?
Totally. So opioid disorder was sort of catalyzed by different elements. Number one, there was a lot of misinformation in the beginning part from the pharmaceuticals indicating that the opiates being prescribed, they don't have a high risk of addiction or being dependent on that. And also having pain as that fifth vital sign are really, and which is a subjective report. So it makes it really challenging to really have an objective or a really concise way of identifying a pain, on a pain scale. If a pain scale of 5 from one person may not be a 5 for another. So there are a lot of variables that come along that, which makes it very challenging to really get to the core of that. When older adults and other patients suffer from pain, pain medication is prescribed. The longer you use opiates, the higher the risk of developing opiate dependency. When you develop opiate dependency is not addiction, but opiate dependency just means that, yes, you use the medication for the right purposes, but you're right in the fine line of where benefits and risks can tip over. So you still continue to use that, but you're right on that fine line. And then after that, the scale can move over to addiction or substance use disorder, where now the risks outweighs the benefits of that medication. And that's why it's very crucial with the assessment of pain, really having not only asking the pain scale, how bad the pain is, but looking at other physiological aspects that may indicate presence of pain to really put these 2 and 2 together to come up with a good picture of how bad the pain could be. But at the same time, respecting people's report of how the pain scale of what their pain is, but really combining this together, that will be definitely be helpful. So the opiate dependency transitioning over to opiate use disorder is when you use the opiates not for the primary reason of them being prescribed for, but rather to satisfy the dependency that you do have, where people escalate their doses taking more than what's prescribed, or asking other people for medication, or running out of the opiates ahead of time than your doctor has prescribed for that. So if you realize this is happening, that's sort of one of the first signs of developing opiate disorder from dependency. And it's really crucial to address that with a primary care provider, the person prescribing that, to address that appropriately.
Yeah, definitely. Even people, if people are prescribed opioids, any type of narcotics for pain, even if they don't have any type of dependency, it's always good to put the medications up and away so that nobody can see what you have, because you yourself may not have a substance use disorder. But you just never know these days, especially the way people are suffering silently. If you have somebody over your house, and some people might be curious to see what you have in your medicine cabinet, or if you have children living near you or living at your home, or if you're babysitting your grandchildren or other people's children, it's so important to just make sure that the medications, especially, all the medications that you're taking, are put away, so that way it is not within arm's reach. Because I know this is a little bit of a tangent, but it's just a very important, because a person may not have substance use disorder, but other people who may be entering your home may, and you might, they might take, some of the medication. So just something worth noting. Now, George, as far as what type of patient populations have you been in charge of recently? What type of substance use disorder have you been noting that people are coming in with most recently, especially during the pandemic?
Totally. Alcohol use disorder has really skyrocketed over during the pandemic, and we have had an increased number of both patients with mild withdrawal symptoms to extremely significant withdrawal symptoms for that case. So that has really escalated over time. And also, we've had patients with substance or opiate use disorder, and it's before the pandemic, people would mostly visit their clinicians physically in the offices to do the appropriate monitoring for any prescribed opiates or patient who might need opiates for pain. But also there's some risk of a substance use disorder, but just being isolated and not having that and doing switching over to telehealth. So a prescription of this medication without close monitoring that a clinician might need also might have put patients at risk for overuse of the medication at home and after running out. So really just given this they don't have that close monitoring as they had prior to that. Also, as I mentioned, over the last couple of years, the state and the federal have really created a lot of very strict policies and rules in regards to the prescription of that, which did sort of have the providers be more stricter in terms of prescribing opiates. And patients who previously were being prescribed high doses of opiates and the clinicians not being comfortable anymore to do that, that has propelled over for older adults and patients are really replacing that with other opiates which are obtained illegally. That could be heroin or patients who, as you had mentioned clearly, they know other family members who have opiates in their house trying to get that from them too as well for that case. So to answer your point, yes, that has increased over the last couple since the pandemic, and isolation is thought to be a huge factor, and that lack of engagement and monitoring that's needed for patients who are at risk for developing substance use disorder.
Mm-hmm. Now, for people who may suspect that a friend or a family member may have substance use disorder, but just don't know how to approach that person because they feel like that particular friend or family member looks like they're really suffering and they're just, they're not able to take care of themselves. Maybe they're disheveled or they're missing their their work schedule. They're just not as visible. What is the best way for friends or family members to help that particular person? What type of conversations, questions? Do you have any tips for us?
Sure. That is a very challenging conversation for sure. I think the initial point is really approaching it in a really non-judgmental way. And it's not approaching it to a point of telling them what they're doing wrong, but rather from a perspective of, I have realized something is not right, and I want to help you to get things better going forward. So really approaching that in a very non-judgmental way. And one of the things that may be very beneficial, it's really kind of elaborating the progression of things getting worse over time, having some objective things that have happened over the course of a year, or as you mentioned, you did have a really great job, or you had these responsibilities which you were able to take care of diligently, but over time, the focus you have not had the capacity or the capability of doing so, and also, or maybe the main thing has been perseverating about getting the substances that you need. So having some helping the patient see themselves, helping a person to see themselves from a different lens, that definitely might be helpful. And asking them what if they have realized any changes, really trying to tap on how they view things from their end. So understanding that, and a lot of patients who may have substance use disorder, there's a lot of denial, there's a lot of shame, as you mentioned earlier, given the stigma that associated with that. So creating a good and creating a comfortable environment for them to have that conversation as well. And I think that third part will be to really try to discern what the root cause is. So when somebody or when substance use disorder comes, it's sort of the last symptom of something that might be going on. Is it they're trying to treat depression? Is it there are things that are going on they're not able to cope with very well? If we are able to help them cope with them in a different way or a better way or less harmful way, then can you be able to direct them and offer support to treat the root cause for that? And I think approaching it from a point of not wanting them to stop. I think that's another rather cut down and be able to get better over time. Substance use disorder develops over a period of time. It's not something that develops overnight. So a chronic disease like substance use disorder that's created over time, having that patience of working through over time, working through the frustrations, working through the denials, and really taking the time on creating sort of realistic expectations for that. So instead of advising or recommending for a family member to stop drinking completely, how can we cut down from drinking this amount and we go down to a less amount where you're comfortable? So gradual progression around it, using mental health support, talking to your provider to get some support for pharmacological support for the medication, and addressing any root causes that might be triggering that. So that might be helpful as a tools to use when having the conversation with a family member.
Definitely. And not to stop whatever substance that they are using cold turkey.
Correct. That
right?
will definitely trigger the withdrawals, definitely.
Definitely. So I'm glad that you said, maybe tapering, whatever it is they're using, but definitely seeking medical attention. So that way they have that supervision and also the proper way of tapering. So we have a few more minutes left. George, can you just briefly, I'm trying to have people understand where you fall into the healthcare system. So a person gets admitted to Tufts Medical Center. At what point would somebody say, oh, we need to consult George, or we need George's help so that this patient can really get the maximum benefit of their stay here?
Sure. So there are sort of two main areas that I'll be reached out for. Number one, if it's a person who has been in the hospital over and over multiple times, multiple readmission for either the same reason or for related reasons for that case. So at that particular time, I normally collaborate with the team members, trying to really get to the root cause of what's really causing this readmission, offer a different eye in regards of is there something else that we are missing from our end, or what's needed from the patient side. So from a clinician side, everything being done diligently, as well as what is a patient's responsibilities and how we can try to support them. So really addressing a root cause for that. A good example will be somebody coming in with shortness of breath caused by heart failure, and they be coming over, getting treated, getting discharged. But medical team try to treat that. So my role will be what's really propelling that heart failure. Are they having issues obtaining their medication at home, or are they having challenges trying to comply to their medication regimen? Is it so complicated that we need to involve the pharmacist for that? So it's really looking at the root cause of what's causing the presenting symptoms for the patient. The second part that I've been involved in is a patient or a client who may have different aspects of the medical issues that are correlated. I normally call them the biopsychosocial, where there's a complex clinical presentation. There is a complex behavioral health, mental health element on that. That could be really severe depression or delusion and whatnot, and also psychosocial, where they don't have the support that they need at home. I think we all know that the care that we provide in the hospital is very crucial and very important, but it's equally important to make sure these patients are connected to the right resources in the community to make sure they continue getting their appropriate treatment, and there's no fragmentation in regards to what's done. So really partnering with people in the community, trying to really connect them to what's needed to make sure they stay safe and at home.
Wow. Good. Well, thank goodness for you, George. You make it sound easy, but I know that there's a lot of research back and forth and communication with the patient, maybe the patient's family if they have it, patient's significant others, friends, and making sure that the care that they have at the hospital, and also that the care that they will have after they leave the hospital is going to be as seamless as possible.
Totally.
Yeah, definitely. So we're at the top of the hour. So I want to thank you, George, for being here. I learned so much from you, and I hope the viewers also. If they have any questions, how can they email you to learn more about what you shared? So that way, they're, if they have any questions, they could email you.
My email is right on the screen. So it's gguara@tuftsmedicalcenter.org. That's probably the best email that I can be reached at.
Great. Thank you so much. And again, thank you. And I want to thank the Quincy Public Library for allowing me to continue my outreach work on falls prevention. I wish you all a healthy and happy and safe day. Take care. Bye-bye.